What is prostatic artery embolization and when is it needed?
Prostate artery embolization is a novel and effective procedure for patients suffering from benign prostatic hyperplasia, that's BPH. So first of all, we should know what is embolization. So embolization meaning to stop or to block the arterial supply of any organ or the part of body, or we can say some tumor, with the help of sand-like or salt-like calibrated particle with the help of micro catheter. So if we talk about the prostatic artery, so those patients, those who are suffering from benign prostatic hyperplasia, in those patients, first of all, we do angiography of prostatic artery, and with the help of micro catheter and super selectively, we go into the prostatic artery branches and we do embolization for those artery, and all those symptoms of a BPH patient, they are relieved within 4 weeks. Next question was that when is it needed? So as I have already mentioned, all the patients, those who are suffering from benign prostatic hyperplasia and lower urinary tract symptom, for those patients, prostatic artery embolization is very safe and effective method for treatment.
What are the advantages of prostatic artery embolization over conventional modality of management?
After diagnosing BPH, previously there were only two kind of treatment method. First one was medications, so like alpha-adrenergic blockers and 5-alpha reductase inhibitor, phosphodiesterase 5 inhibitor. But those medications, they had their own side effect like hypotension, headache, dizziness, erectile dysfunction, ejaculatory dysfunctions. And then surgery came into the picture. So there are different kind of surgery like TURP, TUIP, hydrodissection, laser vaporization, or some sort of clipping and stapling. But again, those procedures, they have intra-op and post-op complications also, and they also have side effects. So between these two treatment modality, we have one very advanced, safe and effective treatment option, which is PAE, prostate artery embolization. And the beauty of this procedure that we do not need any kind of general anesthesia, no cut, no suture, no incision, no bleeding.
What is your clinical experience and the present literature evidence on this procedure?
There are multiple prospective case series, randomized controlled trials, and meta-analysis. So if we talk about some, there are prospective case series or randomized controlled trial, especially by NIH, and there are several articles on PubMed and Radiological Society of North America. So as per the randomized control trial, if we compare TURP with prostate artery embolization, so the clinical success rate is almost 100% for both the procedures. And if we talk about the complication, yes, definitely there is 56% ejaculatory dysfunction, which is temporary with prostate artery embolization, while 84% in TURP surgery. And the IPSS score, which is International Prostate Symptom Score, the quality of life index, the Qmax rate, which is the maximum urinary flow rate. So there is no marginal difference between these two procedures. At 12 months, success rate is almost 85%, 30-month success rate is 84%, while 78-month success rate is 76% in prostate artery embolization.
What is radial approach and its benefit for the patients?
Nowadays, we take radial artery puncture at wrist with the help of ultrasound guidance, and from radial artery approach, we goes to the prostate artery and we do angiography there and then embolization, of course. So we have specialized hardware and radial artery approach. As a doctor point of view, it makes procedure very easy for me, and there is less radiation for me and my patient. It is less time consuming as compared to femoral artery. There are few side effects or complications associated with femoral artery puncture, like there can be groin hematoma, and in rare cases there can be pseudoaneurysm formation. But if we talk about radial artery, so definitely it is better than femoral artery because we can ambulate patient immediately after procedure. Patient can take care of himself, and definitely we can discharge patient on same day. Patient need not to lie down on bed for a longer time, and definitely patient can get back to work after 2 or 3 days.
What is your message to the general physicians for patient management in their OPD post-procedure?
After doing prostate artery embolization, patient might complain of some initial or mild symptoms like burning retropubic pain and their acute urinary incontinence. So such kind of mild symptoms should be addressed by the physician or the urologist, and we should start some medication. Patient require urinary catheter in acute urinary incontinence. So at around 1 to 2 weeks, we can remove those catheter, and follow-up is very simple: 1 week, 2 week, 3 week, 4 week, and thereafter 3 months, 6 months, 1 year, and then yearly follow-up. So follow-up is very important, and mental satisfaction is very, very important for patient. The physician sympathy towards patient is very important.